Opioids are a class of medications that are derived at their base from opium, and heroin is sort of the originator of all opioids. Historically, they've been used to treat acute pain. That's where they work best. They work if you twist your ankle really bad, if you have a broken bone, if you've had surgery. Over the last 15 years, they've been used more and more to treat chronic pain. The issue is related to both the effectiveness for long-term pain and that they are highly addictive medicines and that they have a high risk of negative consequences such as overdose and death from overdose. The most common one used in this community would be hydrocodone. Oxycodone is a close second. And then there are much more potent medications like DILAUDID and especially something called FENTANYL, which is extremely potent. But we understand now from lots of evidence that the acute inflammation that causes pain when you have tissue injury, that pain is almost always much less within 3 days of the injury. Even if it's a severe burn, as long as you're not touching the burn, that pain from the burn tends to go away. We typically would always give people 10 days worth of medication when we only need to give them 3. And most people actually don't use that extra 7 days. They put it in their medicine cabinet at home. And that is there, and I like to refer to this as the burden of narcotics that we have within the community. They're setting in people's cabinets at home. They're there, and people use them, or say they might use them at some point in the future, and that can be a slippery slope. But also that is access, especially to teenagers, that should not be there. I strongly encourage everybody that has any controlled substance at home that they are not actively taking, that they get rid of it. And there are places, the police department has places where you can go and drop off those medicines and just get them out of your house. There's no reason to keep them there. For longer term use, you need to protect that medicine and you need to make sure that nobody else has access to that medicine. Most physicians will contract with you that you have to protect that medicine and it will not be replaced if it is lost, if it is stolen, because of the concern of not using the medication appropriately. Doctors have known for a long period of time that people can get into trouble with narcotics and addiction, and we also know all of the side effects that can happen with that. But there was a push about 15 years ago that started us down this path, and it was triggered because there was a perception that we were under-treating chronic pain. Because of that, doctors were encouraged strongly to not let somebody be in pain. And primarily it became, when you have that kind of goal, you have to use potent pain medications. And so that started this, and then it has perpetuated a lot of people getting on these high-dose, strong medications, and some of them getting addicted to them, needing more and more medications, which put them at much higher risk for overdose and death. Within the system itself, we have addressed it through the providers, looking at a couple of key things. One is we don't want to have a burden of narcotics sitting in people's medicine cabinets at home. And we also, when we know that they only need those medicines for 3 days, we've taken away the ability to prescribe more than 3 days without doing extra work. So the automatic default is to prescribe for 3 days as opposed to prescribe for 10 days. We've also aggressively looked at surgery, and especially elective surgery, and post-op pain control, and how we can decrease the need for narcotics. Interestingly enough, as you do that and you use other modalities like nonsteroidals or central nerve acting medications that do not cause addiction, you actually have better pain control. They get out of the hospital sooner, they can move better, they don't have the side effects related to the pain medication, and they're feeling better sooner and they're going home sooner. So that's the prevention. We're trying to prevent some of that impact we will see relatively soon, but we'll see the real impact of that 2-3 years down the road, that we're decreasing the burden of the narcotics that are out there. So then the other big thing that we're doing is looking at people that are on chronic opioids right now, and especially the higher doses that are related to increased risk of overdose and death. There are clear guidelines from the CDC about those numbers, and we are working within the ability of the electronic record to help the doctors see that and to warn them when they're starting to get up in those higher doses. Are you sure you want to do this? Making sure that the patients understand that as you start to get up those higher doses, that you really are at risk for death related to this, that you really should have a reversal agent at home in case you overdose so that a family member can give it to you. Putting up those very clear evidence-based guidelines, but allowing real-time access to them. And you have patients that are telling doctors, do I really need that medicine? Or is there some other medicines that we can try to get through this period? Or if I do need it, how long am I going to need this for? And that's a question because the doctors are getting educated on this, so it's okay to say, how much of that are you giving me? Because I don't want any more than I need. At the urging of our board of directors, we started really seriously looking at this probably sooner than a lot of hospitals in the area. And it's being at the front of it, hearing that it's horrible in Ohio and that it's coming our way, is to get in front of it sooner. So strong support from our board and our administrative leadership to start asking the important question on how we can do this. Once we started to have the conversation with the providers, that the feedback was very positive, and they were looking for guidance and support on changing our prescribing practices and getting the tools to them so that they can do that real time. As a community, we've recently started a collaboration with the Public Health Department, the police departments in Cedar Rapids and Marion, the schools, and the mental health providers in town. There's also representation from the Iowa Board of Pharmacy, which monitors use of controlled substances across the state. One of the things that Mercy is at the forefront of is, before that collaboration started, we started to collaborate with the Iowa Board of Pharmacy, and I actually have already developed that relationship, and so we are going to be piloting a very close relationship with the Iowa Board Prescription Monitoring Program so that we will have real-time access to our patients' use of controlled substances. We're already seeing, I think, improvement, and a lot of that initial rapid improvement is going to come from the patients. The patients saying they don't need this, or getting rid of it if it's there in their house and they don't need it any longer. That's going to be our quickest. I think that providers are going to change fairly rapidly. And if you look at provider prescription changing, it typically takes 2 to 3 years for providers to shift significantly. But I think it's going to be quicker here. The providers have been waiting for this and wanting it. And I see it, I review charts all the time, and you see these long conversations that happen in urgent care settings or in emergency room settings about how to best control their pain and using things that are non-opioid unless you need to use those opioids. And those conversations are happening now. So I think that we'll have a rapid change, and then we will have the more difficult, slower change that will happen to people that are already on high doses of these medicines. I am optimistic. Part of it is maybe being in Iowa. We have support from the board and the leadership and the providers, and the community is coming together as a whole. I like to think that we will never get in the position of a state like Ohio that is fighting backwards, that we're in front of it.